So good afternoon, everyone. I'm Dean Ramona Benkert, and I'm so very pleased that, this is too loud. It feels like feedback to me. It's good? Okay. So on behalf of the faculty and staff here at the College of Nursing, it's my pleasure to welcome you to the college's third annual Dr. Virginia Hill Rice Endowed Lectureship. Today's talk is thanks to the generosity of one of the college's own nationally renowned researchers, Professor Emerita, Dr. Virginia Hill Rice. We're able to gather today for this thoughtful dialogue on the future of interprofessional education and practice. And of course, it's no surprise to those of you who know Dr. Rice that she really wanted us to focus our eyes on the future. What should we be thinking about with this topic as we move forward with this ever-changing healthcare system? So while there's a longer biography in your packet, I just wanted to give you a little bit of information about Dr. Rice. Dr. Virginia Hill Rice is fondly known as Ginny to all of us who've known her for many years. She was a tenured professor in the College of Nursing and a professor of oncology at WSU College of Medicine and the Karmanos Cancer Institute. She began her professional career with us in 1982 as an assistant professor, and she retired as a professor emerita in 2015, serving in numerous leadership positions in those 32 years. Ginny is a fellow of the American Academy of Nursing and proudly served as a member of the Health Advisory Board for the Arab Community Center for Economic and Social Services. Her research focused primarily on patient education, stress and coping, and tobacco prevention and cessation. Ginny and her team were the first to focus on the deleterious effects of water pipe smoking, or hookahs, and the health of adolescents and older and adults from the Middle Eastern and Arab American communities. She's passionate mostly about her students that she's mentored over the years, and many of former PhD students from Middle Eastern countries are now leaders in academic nursing and health systems from Jordan, Kuwait, Egypt, and the United Arab Emirates. Unfortunately, Ginny couldn't be with us today because of some health issues. And her son Garrett also was hoping to be here and couldn't be here. So they've asked us to tape, and fortunately our speakers have been graciously willing to record today's session. And the plan is for Garrett and Ginny to watch the recording in a couple of weeks. So given the topics of today's lecture, I asked the health professional deans here at Wayne to share brief remarks on the importance of interprofessional education and practice to our professions. We have with us Dean Weil Socker from the School of Medicine and Dean Brian Cummings from the Eugene Applebaum College of Pharmacy and Health Sciences. Unfortunately, Dean Kubiak couldn't be with us because of some professional travel, and her associate dean, who was supposed to be with us, became ill. It's just the time of year. So Dean Socker, would you like to come up?
Thank you so much, Ramona. It's an honor and a pleasure for me to be here, and allow me to speak spontaneously without remarks, because I did know Dr. Rice for quite a while, actually. This year marks our 25th year since we knew each other. 1999, and is Linda with us here? Linda, hi, Linda. We started the first health issues in the Arab American Community Conference together. A handful of people, Linda was with us, and that's how I got to know Virginia. She was an absolutely great force in everything she did, with enthusiasm and with conviction. She'll always speak her mind, listens very well, but then really bounces back with some of the best advice. As you heard from Dean Benkert, she focused on certain areas within a big segment of the community in Southeast Michigan, that's the Arab American community, and looked at smoking effects and smoking addiction, especially in adolescents and high school students, looked at the hookah effects, which was just going everywhere, exploding here, and unfortunately in many cities in Europe and around the world from what one can see. She worked on stress and coping. She was very prominent in the American Heart Association. So, and was a force in that conference that I had the privilege of chairing its scientific committee for 4 circles for 8 years. The other thing that I really learned with Jenny and from her is the topic of this conference, the interprofessional education, research, and practice. As a younger physician at the time, I had nurses in my family, but looking at someone in a leadership role like this, who is conducting these big programs for years, and also channeling them into conferences, into education. We co-edited the proceedings of the conference along with others, including Linda. And it cemented in my mind the real importance beyond the just the concept and sometimes the sentiment of interprofessional. It's the practicality. We're talking about the community work, the great benefit of having good communications with patients, the great benefit of reducing the medical error when there is such a collaboration, and patient safety. So I have everything to say, every great word to say about Dr. Rice. And I thank you very much for honoring her with this endowed lecture. And I thank our keynote speakers for being here. And it's a pleasure to be with you. Thank you.
And our next dean is Dean Brian Cummings, the dean for Eugene Applebaum College of Pharmacy and Health Sciences.
Thank you, and good afternoon, everybody. Thank you, Dean Benkert, for inviting me to be here at this event. And I think it's fantastic. And thank you for truly modeling interprofessional education by inviting not only me, but Dean Sacker to this event. Fantastic example of what we're talking about here today, and just an example of one of the reasons I'm just really proud to come back and be dean at this university in the health sciences, because this is a university that truly values interprofessional education and models it, and doesn't do it just talk, but they do it and they walk the talk. My own college has 12 different programs in there, and not only pharmacy, but you've heard we've got physical therapy, mortuary science, radiation therapy, technology, rad tech, physical therapy, physician's assistant, almost all the allied health sciences. We've even got some nursing mixed in there with nurse anesthesia. And for decades, not only in our college, but at the university, as you've heard from Dean Sacker, why we've been successful in doing what we do and taking care of the health of the citizens of Detroit and the state of Michigan, as well as the nation, is that IPE has been integrated into all of our college curricula. And we do this to take advantage to train our students to work in healthcare, not only across campus, but in all areas. And this includes the College of Nursing. It includes the School of Medicine, as well as my own college. And this just isn't curricula. By creating these infrastructural elements, what you see is not just here, but when you go and you look at these clinics where our students are working, you go and look in the hallways and you see students from PT, OT, talking to medical students, talking to nursing students out in the hallways around the water fountain, comparing cases and discussing, then you realize what we're doing here is not only intentional, but it's strategic. We create cross-college IP events to make these things happen. We build around patient cases. We get many different views. In these group discussions, and these hands-on exercises give students a chance to see the big picture, how it works. And we do this really with the focus on holistic patient care with one overall goal in mind: to work as a team, without egos, without agendas, with one goal in mind: to provide the best healthcare possible for the patient. Now, whether it's through these committee initiatives, skill building workshops, or even these hallway chats that I'm talking about, the constant exchange of ideas and different views from different healthcare providers really is one thing that makes Wayne State University and their commitment to healthcare of their patients fantastic and nationally and internationally known. And it's something, as you've heard from Dean Sacker, that we have been doing from the start. And I'm so proud. And it helps the students remember that the privilege, and it is a privilege, and we remind them this, to be entrusted to take care of the health of another individual. And by providing IPE and by highlighting it, such as this College of Nursing, they keep us reminding of what a privilege it is to work with you all, to work in teams, and to take care of a patient's health. Thank you.
So I just wanted to share briefly the commitments to everything that Brian and Dean Cummings and Dean Sacker have said is really the commitment for the College of Nursing also. But I really wanted to speak a bit about something that you may not know about the Wayne State, is that we are the program office for what's called the Michigan Area Health Education Center. And many states have what they call an AHEC. Ours is extremely unique in the fact that it is co-led by myself and my colleague, Dr. Jinping Zhu, who is the chair of Family Medicine and Public Health Sciences. And so we also have IPE faculty champions who work with us. So we are, from the outset, IPE. It's an IP initiative for the entire state. And in fact, we are the only joint operated and led AHEC in the country. So thank you, Dr. Zhu, for being here. So now it's my great pleasure to introduce our two speakers, Dr. Deborah Trautman and Dr. Kathleen Reeves. Like Dr. Rice's bio, there is a more extended bio within your program, but I just wanted to give some brief overview of our two excellent speakers. Dr. Trautman is president and CEO of the American Association of Colleges of Nursing. As the national voice of baccalaureate and graduate nursing education, AACN serves the public interest by setting standards, providing resources, and developing the leadership capacity of member schools to advance nursing education, research, and practice. Prior to AACN, Dr. Trautman served as the executive director of the Center for Health Policy and Healthcare Transformation at Johns Hopkins Hospital. She served in other leadership positions at Johns Hopkins Medical Institution and the University of Pittsburgh Medical Center. Dr. Trautman has authored numerous publications on health policy, leadership, nursing practice, and nursing education. She is the 2007-2008 Robert Wood Johnson Health Policy Fellow, and she worked with the Honorable Nancy Pelosi when she was then the Speaker of the U.S. House of Representatives. And she is also a Distinguished Nursing Fellow in the National Academy of Practices. She received her BSN from West Virginia Wesleyan College, MSN from University of Pittsburgh, and her PhD in health policy from the University of Maryland, Baltimore County. That's just one half of our excellent speaking team. The other half is Dr. Kathleen Reeves, who is the president and CEO of the Arnold P. Gold Foundation. For those who are familiar with the white coat ceremony that occurs in multiple institutions and colleges, that's the foundation that runs that. She is also an adjunct faculty member of the Department of Urban and Population Science, the Center for Urban Bioethics, and the Department of Pediatrics at Lewis Katz School of Medicine at Temple University. Her previous leadership roles at the Katz School of Medicine included founding director of the Center for Urban Bioethics, chair of the Department of Urban Health and Population Science, senior associate dean of student affairs, and the inaugural senior associate dean for the Office of Health Equity, Diversity, and Inclusion. And she is also a Gold Humanism Honor Society member. Dr. Reeves also served on numerous Association of American Medical Colleges, or AAMC committees, as appointed by the governor of the Commonwealth of Pennsylvania to the Pennsylvania Commission on Crime and Delinquencies, School Safety and Security Committee. She earned her bachelor's degree from Juniata College, graduated from Sidney Kimmel College of Medicine at Thomas Jefferson University, and completed her pediatric residency at Cincinnati's Children's Hospital Medical Center. She's a board certified in both general pediatrics and pediatric health hospital medicine. So please join me in welcoming Dr. Trautman and Dr. Reeves.
Thank you very much for that incredible introduction, for the wonderful words that you've both said. Leadership here is clearly a role model across the country. I also want to say that we are honored and appreciate Dr. Hill Rice's commitment to this lectureship. I was supposed to be here last year and I got COVID, so I couldn't come. I'm very glad to be healthy this year and to be joined by an extraordinary colleague. We are going to break up the session, so we will have some time. I'm going to be providing a framing and context for the session, and then Kathy will come up, and then we're going to take some questions. So we look forward to time to engage with you. I am genuine about the excellence that your university, that Wayne State University, is truly leading. And for all of us, though, there is not yet the degree of uptake that we need in interprofessional education and practice across the country, and quite frankly, across the globe. There is so much more that we need to do. I'm going to provide context of information that you already know. Some of it is not going to, of course, surprise any of us, Kathy and our pictures, but we're going to talk a little bit though about the trends that you're already familiar with, but the trends in healthcare and higher education, and again, emphasizing why it is so important then to have interprofessional education, practice, teamwork, if we're going to be successful in dealing with. Rear Admiral Mix said one time, she doesn't call them problems, she calls them challenges and opportunities. We have an abundance of challenges and opportunities in front of us. And then we are going to talk some about, again, the status of interprofessional education practice and the importance of humanism. And most importantly, as this lecture is about, for all of us to consider the implications for the future. So the trends in higher education that you all are familiar with, it wasn't so long ago, I went to a conference and someone said, well, is artificial intelligence just the new shiny thing? Well, we clearly know it's not the new shiny thing, here to stay. And what's important for all of us in higher education is not just importantly understanding how we will effectively utilize artificial intelligence in higher education, but how we are also going to contribute to its continued development. I talk to people on the train. I ride the Amtrak train down from Baltimore to DC every morning and happened to sit next to a gentleman just a couple weeks ago who is an entrepreneur, started his own third company now. He's a tech person, and his most recent one is an AI startup. And I said, all right, I'm going to be talking to some folks, what's most important to say about AI? And he said, whoever you are, wherever you're working, he believes that what's most important is AI exponentially will help us achieve outcomes at a much faster rate than we've ever been able to before, but not unless we're purposeful and intentional about how we use it and what it is indeed that we want to achieve, but to not be afraid of it. But anyway, I was one of those people that originally thought, well, maybe it's not here to stay, but I have certainly changed my mind about that. We all know the finances that our institutions face are incredible, but so are the finances that our students are facing. We are under increasing pressure. It's down here on the next one outcomes and accountability, not the next, but when I first started my career, I don't remember higher education being challenged, asking, does higher education really worth what we're paying for it? But that's happening, and it's happening across the aisle. And down in DC, it's not just Republican, it's not just Democrat, it's both parties saying, are we really getting what we're paying for? What is the return on investment? So that's one of the challenges and opportunities we have, demonstrating that indeed the investment in higher education is worth it. We know that there are new business models and, importantly, more partnerships that are happening in higher education. I'm sorry, I should have mentioned, these trends are pulled from, but any resource that you pick up, you would find many of these come from the Higher Learning Commission. Every year it produces a report annually about what the trends are. So that's where we pulled most of these from. But also that short-term credentials is relatively new, some would say, and a renewed interest in advancing more short-term credentials. Mental health and leadership are not new challenges and opportunities for us, but we must be more intentional about what we do to address mental health for students, for faculty, and for those that we're caring for as well. And while many would say we've made advances, again, there's still so much more to do. A colleague of mine is a psychiatrist, and he now has 7 states that are a part of his practice because he's using telehealth. And I remember years ago, I wouldn't have thought that would have been effective. He said it's been phenomenal, and the outcomes they've been able to achieve with their patients and the work they've been able to do in communities. But again, more to do. And then leadership. We've all known leadership is important at every level. I talked to recently some folks who asked about university leadership, and they said, well, maybe not. I mean, but you need so much resilience, all of us in our leadership positions. But again, there's so many challenges. But when you work with a team and you're willing to build a team, leadership in these times, in these turbulent times, can be very rewarding, and we can achieve the outcomes we want. But we're going to be continuously faced with challenges as leaders. We all know, and it matters not where you sit, diversity, equity, inclusion, and belonging are important. There are some that are framing in the initiatives, AACN, this is a part of our values. Some are framing it as intentionally being exclusive. That is not what we're talking about, but we recognize that we all come from different perspectives. We're not just talking about how we look, but how we think. We know that a more diverse population is the world in which we live. And we expect that it would be, and there's data that supports that it's important to have a diverse workforce. It's important we learn more from each other in our diverse communities. But more and more as a society, we live in groups that look more like us. And what we need to do, we've been working to be intentional about how we support diversity, equity, inclusion, and belonging. There are challenges that are coming across the states. In the association world, we need to be careful that the language we use doesn't create unintentional barriers to our members participating. And we've had requests from our association to respond and discuss the initiatives that we have to assure that our intentions are about belonging for all individuals and all parties, but recognizing that there are different circumstances. There are parts of the country that, for example, have limited access to care because there aren't pediatricians there. You can't argue that you need to do different things under those circumstances, so there are not universal solutions. But we will be, our association, and I know many, continuing to be committed to diversity, equity, inclusion, and belonging. And then I love the journey that we're on about competency-based education. Every health profession is moving forward with competency-based education, but many would agree that we're still pioneers in this space. What's most important is the outcomes, what our students know, what they can do with that knowledge. And this is a great opportunity for us to do more in interprofessional education and practice. And my grandmother had a saying, it's like a toe in the water. That's about as far as we are right now. I think there's so much more we can be doing, and hope to hear, and you've already shared some examples here, but we're trying to gather more examples from across the country. Now in healthcare, we know that I was just at the National Academy of Science meeting last week and had the privilege of listening to Dr. Richard Besser from the Robert Wood Johnson Foundation and Dr. Victor Zhao from the National Academy of Science speak to a group in one of the receptions. And they talked about, we've been discussing how this wonderful group of leaders in the room, and they weren't being insulting, they were being respectful, has been talking about transforming the healthcare delivery system for decades. While we've made progress, we are not yet receiving high scores collectively across the country. We still have so many problems, and that's just one of them. We know that hospital systems continue to be in crisis, not all of them, but many, still with respect to financial resources, with some of the challenges about access to care. And this list, again, is pretty extensive and exhaustive. Senior care, we have an aging population, and yet it's one of the areas where we still have so many needs, and our inability to find ways to provide more resources to seniors to keep them in their homes or to keep them safe in certain environments. So the list of challenges and opportunities in front of us, again, I will repeat, is abundant. But many believe that in order for us to address these issues, the stronger we are as an interprofessional practice and interprofessional teams, the better able we are to address. And if that weren't enough, now this state is old and I'm pleased to say it's not going to be as bad, but there still are shortages. This data was in 2021 and it predicted a 3.2 million shortage. Now this is healthcare workers across all. There still is a predicted shortage, but it varies by geographic area and it also varies within professions. But these are facts about what happened during the pandemic. 18% of healthcare workers quit their jobs because of the stress, the burden, and the toll from the pandemic. 47% of healthcare workers, and this was 2 to 3 years, we've almost realized that 47%, just short of it, left the healthcare profession. And there are individuals, when you ask them about their interest in entering the healthcare profession, they'll say, maybe not so much. The way that some in the profession describe the work, and it's not just one discipline, individuals are saying, I'm not really sure that's what I want to do. So I think when we think again about the importance, it isn't one discipline alone that needs to ignite excitement about working in the health professions. It's all of us. Now, that's why we come to interprofessional education and practice. I am going to speak a bit about what you already know from the World Health Organization, which in 2010, yes, 2010, said how important it is for us as healthcare professionals to learn with, from, and about each other. I remember the first time when I was at Hopkins and we started our IPE work, we brought medicine and nursing students together. I was stunned at what we didn't know about what the other one's practice was and or their education. And Hopkins had a commitment to doing more for IPE. We couldn't even get a class because our schedules were so complex. So there are many challenges, and I've been gone for a while, but Hopkins has come a long way, as many other institutions, but we have, again, much more to do. In addition to what we do as healthcare professionals, I also grew up at a time where we didn't involve the patient, the family, the community nearly as much. And I'm really, myself personally, pleased to say that I think we've come much further in this space, recognizing that it isn't one entity, one of us, it takes all of us. So that is, again, interprofessional collaborative practice involves our patients, the families, communities, and those who provide the care. I had had the distinct honor and privilege of being the CEO of AACN since 2014. And when I came in, I was, because of the position, began serving on the board of IPEC, the Interprofessional Education Collaborative. In 2019 to 2021, I was able to serve as the chair. I believe that the leaders, the founding leaders who are in this picture here, were absolutely extraordinary. Visionary and committed. They tell me to this day they chose not to take on scope of practice at the time. That created a little bit of stress. Now they said they would, but they didn't do that then. But they had a vision for what was important, and they were focused primarily on what we could do as health profession education associations. And there were 5 at the time. There were, oops, I just want to make sure. I write them down so I don't forget. But medicine, nursing, pharmacy, public health, and osteopathic medicine were the original organizations. The mission has been modified somewhat over the years, but it's still very much true to the initial intent, which is that we should be working to prepare healthcare profession workforce in an interprofessional collaborative way, which again, you all know. And then the vision is that why? Because it makes a difference. And they stayed strong and stayed committed to that. And I am pleased to report there are now 22 national associations of health professions education that are a part of IPEC. And it's one of several, but it is a key association, a coalition collaborating to do more to advance, excuse me, interprofessional education and practice. This was actually already said in some of the opening remarks, or some of it, but first of all, I think it's probably even higher, I believe, than 85%, but very few of us make it through life without some encounter with the healthcare delivery system. And this is annual data. So individuals have an experience with the healthcare delivery system, and that experience isn't always good. As we know, there are medical errors, we are having unnecessary care, we have preventable deaths, and we have, as you know, malpractice claims that come about. And there is evidence that shows that when we work better as teams, when we have stronger interprofessional practice, we diminish these results. And then it is projected that we are going to have, the numbers vary depending on who you're speaking with, but that we are going to have a shortage of healthcare workers. So all of this, again, if we didn't believe it before, makes the case for we must have effective teams working to take care of those who need healthcare, working to make the system better, and doing much more to promote a healthier nation, and quite frankly, across the globe as well. So just briefly, because I didn't live the 2011 were the very first IPEC. These are the core competencies. 2016, they were revised. And in 2016, the major change in 2016 was the inclusion of public health. Even though public health was a part of it initially, it wasn't that expansive. Now I have to look at my notes because there were several major changes for 2023. And those include the inclusion of the quintuple aim, One Health, shared servant leadership, well-being, and resilience across all of the areas, recognizing that the competencies needed to be more measurable, streamlining the overall approach, and having broader applicability. Initially, these competencies were for pre-licensure in the different professions, and now it's intended to apply to any learner. There's a slide that's going to have a QR code that you'll be able to, I'll come to it after this one. You'll be able to download, if you haven't already, the IPEC competencies. They're being used across the globe. There's a new visual as well. But now you can see it's not just in the United States. Over 24 countries have now downloaded. There's recognition that this is important globally. And then again, this is the core competencies. You can download the revised framework. Now, IPEC said, we know it's important, we believe it's important, but one of our members happens to be the Association of Academic Health Sciences Libraries. So that member group helped work with others to conduct a scoping review. Let's look at what's published thus far. Now, I would say they and I and others would agree that we need more publications in this area, but there's sufficient, publications to tell us that it makes a difference. But the question particularly was, has the inclusion of IPE in healthcare curricula had a direct impact on the quality of patient care? And what they found in this scoping review, and there's a publication that I'll also have a link to for you that you can look at later. Length of stay decreased, medical errors decreased, patient satisfaction increased, caregiver education improved, and mortality decreased. So again, it makes a difference. There's robust evidence there. Again, if my grandmother were around, she'd say, well, why isn't it going further? Why aren't more people taking up the cause, she would say. There are reasons for it, but I think that we have to overcome what those barriers are. In summary, with respect to this publication, patient care improves, patient outcomes improve, and the satisfaction of the healthcare professional improves when you're working with a team, a group of colleagues that you have respect for, you know and understand, you trust. It makes a difference. This is the site if you want to see the article, which was published in the Journal of Interprofessional Care, and it's free. And I'm going to turn it over to Kathy, but before I do, I am going to include the quote that I know that I wanted to share, and I shared it earlier with some. Doris Kearns Goodwin, who you all would know, has quoted many, many wonderful sayings from the presidents, but this is her own quote. She said, "There is nothing more important in life than having work worth doing it well, and working with extraordinary colleagues along the way." You all are evidence of that. I am grateful to be here with you today to share these remarks, and I will bring Kathy up for continued remarks.
Well, thank you, Deb, and thank you to the leadership of the school for inviting us. And just before I move on, I'm going to give you all a chance because Deb was great in making sure I had time, but I want to give you a chance to take the picture. So what I want to talk about, I have this amazing opportunity to spend all of my time every day working towards healthcare that's more humanistic. And for me, that means care that is kinder, more compassionate, and more trustworthy. And we have a real problem, right? Even before COVID, there was an article in JAMA that 60 to 80% of the patients who we see collectively don't tell us something important because they don't trust us. I mean, that makes our job impossible, right? So I like to tell people this is the science of medicine. I think relationships and humanism and trust and compassion. I'm kind of old now. I actually, in our ride over, I found out the person who was driving us, who now works here with you, wasn't born when I did my residency. But humanism still mattered then. I did my residency in the early 90s. The science of it was true. Everything I learned in medicine was not. And there's many things. If I did what I learned in my residency today, that would be malpractice. So there is real science behind what we're talking about. And the science of humanism is embedded in interprofessional collaboration. It's embedded in what IPEC has talked about. So I'd like to take the different parts of IPEC and just give some examples: the teams and teamwork, the roles and responsibilities, communication and values and ethics. And I want to share some cases that I've observed that speak to the importance of this, and then use it as an opportunity to say, so what's that mean for us? How do we teach that in this very complicated educational world? So first, let's talk about teams and teamwork. I want to talk a little bit, within this report, everything is categorized into different goals and objectives and competencies. So under team and teamwork, it talks about really applying interprofessional conflict management and looking at an issue where there's disagreement and coming to a space that's good for the patient. Share accountability as a team and operate where we all agree that resiliency, well-being, safety, that all matters. So this is a story of a 15-year-old girl who lives in Lehigh Valley, who was riding a four-wheel ATV without a helmet and crashed. So she was airlifted down to Philadelphia to the children's hospitals with multiple fractures and a traumatic brain injury. She was on surgery service for the first 2 weeks of her stay, and then she was transferred to the medicine service. So she had surgery, neurosurgery, nursing, occupational therapy, physical therapy, hospital medicine, neurology, nutrition, ENT, speech, all as part of her care. And she was physically ready to go to rehab. Her family wanted her in rehab. They could be closer to home. That was the answer to her getting better. But her nutrition was a problem. She wasn't eating. The neurosurgeon was sure she wasn't going to be able to eat. She was going to aspirate. The neurologist was just as sure she wasn't going to aspirate, that this was a behavioral issue associated with her TBI. Not uncommon, right? That happens. And then on top of it, this particular neurosurgeon and neurologist just don't like each other. So they don't like to talk to each other. So no one's talking about what to do. They decide, fine, we'll just put in a G tube. Well, the family's like, no, we're not doing that. So the charge nurse on the floor and the hospital medicine attending get together and say, listen, we've got to get this group in a room without the parents, and we've got to talk it through. And we've got to get to a place that we can talk to the parents. So you can envision it a little, right? Of how it starts. And you can't even do a swallow study on her to see if she aspirates, because she'll aspirate, is, you know, with a neurosurgeon saying, and the neurologist is saying just as surely that she won't. And then this nurse had this great skill to say, you both might be right, but it's not helping the patient. So what if we collectively go together and decide what's the risk? What are we going to tell the family? And the hospital medicine attending is saying, on board, they together are facilitating this environment. And yeah, is it a risk to do the swallow study? Absolutely. But the family gets to hear that whole scenario, gets to understand what might happen. Speech, yeah, it's a risk, but that group together accepts the accountability. One person is not writing in the chart, I can't believe they did that, they should never have done that. And what happened, the parents totally diffused the situation, and it empowered, everybody really wanted it to work, and it worked. And she didn't aspirate. And the more she ate, the more she ate. And within days, she was transferred to rehab. So that's not just a success for that patient, that's a success because it saved money, it got her closer to her family in all aspects. And she didn't have a G-tube. So we're going to come back at the end, just talk a little bit about what that means for future considerations. So one of the other areas in IPEC is roles and responsibilities. So many times, and we don't know what each other does in our professions. You know, I think you're dean of the school that has how many different specialties? 12. You're probably the most educated of any of us in this room. I mean, you told me you now are loving mortuary science, right? But a lot of us don't know that. And the best way we're going to learn that, like we learn everything else, is experiential. So what IPEC says is you do need to include the full scope of knowledge of your team members, and it needs to be person-centered. The Gold Foundation likes that, person-centered. Collaborate with others within and outside of the health system, this community piece, right? Health doesn't stop when we leave the academic health center. You guys are great at that. You know that better than, you live that better than most institutions in the country. And we really need to look at whatever expertise is needed, even if it isn't ours, to address whatever is going to determine this person's health. There are positive and negative social determinants of health. So one thing I really like about pediatrics is we were a specialty that is very committed to family-centered rounds. We do rounds with the family right there. We have a lot of the different specialties right there. Well, this is a case, this was right about a year and a half into COVID. This is an 11-year-old who has who has really significant autism. Not terrible autism, very significant autism. And this is about a year and a half into COVID, where this young man hasn't been to school for a year and a half. And one of the things we started seeing in pediatrics when that happened were the consequences of not having the nutrition that the school provides. Because there are people who can't afford good food. So this young man presented with a fracture and had rickets. Many of us hadn't seen nutritional rickets for years. And so he comes in, we're doing family-centered rounds. We have nursing and physicians and nutrition and social work and child life and OT and PT, and everyone really wants this to work. And it's a lovely family, but the family cannot get this child to eat. And then as we talked to the family, we learned that he had a one-to-one at school, an aide. So we thought, I wonder if this aide can help us. So the charge nurse worked with, it was unbelievable how hard it was, which is something we have to talk about, to get, the family wanted this to happen, the team wanted this to happen, but to get over the legal barriers of bringing this one-to-one aide into rounds on Zoom was such a challenge, but she did it. And so we're on rounds and we bring up on Zoom this school aide, and this young man, this young boy who really was nonverbal, not really expressing emotion, not really interacting or engaging, just started to cry. And he leaned forward to almost hug this computer screen. This aide knew how to get him to eat. So then the next challenge was, okay, well, we have to get her in here and she has to feed him. I must admit, I was doubtful that was really going to happen, but it happened. And that aide came in once a day and he ate. She became part of the care team. So this is the way we do what IPEC says with roles and responsibilities, I think. I do think, though, there's something really important we have to understand about this, which is something that I think Temple did well, where I come from, Wayne State does well. When we talk personalized medicine, I care at least as much that people know what someone's address means as I do about what their genetic code is. There are so many people that work in institutions that have no idea where people live, what school their child goes to. That makes us better doctors. If we know when they give their address, that makes us better nurses. If we know when they give their address, we have a vision in our head about what that means. And this was an opportunity to bring in, the expert needed here was nobody in the hospital, but it made all the difference in the world. So this next, this next example is a little bit different. I'm going to share a tool with you more than just a case. So one of the things that I think really improve what I have seen in my career that improve communication within the healthcare team is when the healthcare team bonds around a patient. They bond around whatever they learned from that patient, about what that patient's life is, about how hard it was to take care of that patient. If we're able to be vulnerable enough ourselves to do that. So there's a tool that the Gold Foundation developed a long time ago, long before I started there, called Tell Me More. And this is a tool that basically is just a big wall sticker that you put on the wall of a patient's hospital room. And on that sticker, people work with that patient to put up on the wall, who are they? What is important to them? Not their disease, nothing about why they're in the hospital, but what's important to them. My most important thing is I love to garden. I have 5 grandchildren. And Tommy is the youngest, and he drives me crazy. I'm a Mets fan. I traveled to 16 different countries. It changes the dynamic. So I may be technically challenged, but I'm going to try to show you just a very quick clip of some doctors and nurses and residents and techs talking about what this tool has meant.
I used to be a community doctor for almost 10 years, and I made great connections with my patients, but I'm a hospitalist now, and now we spend only a couple of days with a patient, and we still have to make these great connections with our patients. Tell Me More is one way to close that gap. I can walk into a room and quickly make that connection with a patient that I might not have.
With the Tell Me More campaign, we've asked patients to share something personal with us, whether it's a hidden talent or what gets them through the day. So they're able to fill that out and then stick it up, and it's on display for everyone.
Sometimes as a patient, you feel that you're not being heard or you feel alone. You would just become another statistic.
They looked at me with their clipboard and wrote a few things down and just left. And I'll always remember that. I just felt like I was just a diagnosis in her eyes.
It's a very vulnerable time, and it helps us understand more about them and their plight.
I feel like the program helps the healthcare professionals. It encourages us to interact more with the patients and interact more with each other. And I might learn something about my coworker that I didn't know, or about a patient that I didn't know. And now I can bring this up and talk to them about it.
Whoever came up with this project is the best one ever. It tells you something that you don't really ask the patient. So I'm connected with that patient. I can easily go in there and have a conversation, and we just immediately connected. So that's really helpful.
You can see from, having been in the department that everybody's sort of been stoked about Tell Me More, and everybody's really upbeat about it. And I think that, the response of the staff has been tremendous.
You want to be more than a patient. You want to be a person.
I felt here I was not a statistic. I felt more like a human being. That's important to me, and I think to everyone. I think what I'll take most out of Tell Me More is the reminder that everyone has their stories, and it makes them who they are.
The big takeaway in my mind is, how can we make this sort of go viral, around the health system? And then short of that, constantly within the department, remind ourselves during the course of the year how important this is.
I was so nervous to end it on time that I went too fast. So just the other day, a doctor of physical therapy reached out to us to tell us a story about Tell Me More. There was a patient who had fallen, and she had hit her head and had a subdural hematoma and was taken to the hospital, and just became a statistic in that hospital. Everyone was doing the right medical care, but she didn't have an advocate from her family there. Her family was not available to come in. And they actually started thinking this woman needs palliative care. Until someone she wasn't responding, she wasn't interacting, she had a bad traumatic brain injury. But someone started to talk with her just about things that had nothing, different kinds of questions, like someone who knew a little bit about her, knew she traveled, and she started talking and she started sharing her world. The opportunity to talk about what her life was changed her diagnosis from palliative care to rehab till she's back at her baseline, which was a fully functioning person. And what happened when that started is she went from this isolated individual who different siloed group of professionals came in and out of her room to she became the center of an interprofessional party where people felt really good about it and started to see her differently, started to see each other differently. So tools that help us communicate with patients that matter to all of us, that is the same for all of us, not a nursing note and a physician note, and then pharmacy does their medication rec, and then we do ours and nursing does theirs. But it's one thing that we all do together. And then the last part of IPEC, you know, I had the great privilege of running a bioethics center. I'm a philosophy undergrad major. Again, I think philosophy is more scientific than biology. I do. The value ethics piece of IPEC is so rich. So I just included them all. You know, it is really valuing the person and the community. Social justice and solidarity matter. Team-based care. I know people don't want us to say the word, and we can use different words, but diversity is going to matter whether we're willing to say it or not. And it matters that we create a culture that's not just allowed to happen, it's intended to happen, which isn't the culture we have across the board right now. And it's Deb's slide again. It's not rocket science to know that's what we need to do. If patients trust, if they feel connected and cared for, everything's better. And the thing that's not on here that also gets better is our health and our well-being. I don't think of what's happening now with people leaving the field so much as burnout. I think it's moral injury. It's not being able to do what we know is right and having to take part in things that we know are wrong. So my last story is in a pediatric emergency room. There's a grandfather who's got custody of his grandson. His grandson's 1 month old. His grandson has a fever. He brings him into the emergency department. He's obviously taking amazing care of this young man. And they examine him, and for any of you in pediatrics, you know he's 1 month old, he has a fever, needs a blood culture, a urine culture, and a spinal tap. And the grandfather says absolutely yes to the blood culture, to the urine culture, and just says no to the spinal tap. So the pediatric resident, excellent resident, taking care of this. He says, no, you really have to. And the grandfather says, no, I don't, and I'm not going to. And you can envision it again, right? It just escalates and escalates and escalates. So the pediatric resident said, well, I'm just going to have to file child abuse charges on you. And that's not an uncommon scenario that happens in our hospitals, right? Well, a nurse is observing all of this, and, you know, as only nurses can do, pulls them aside and said, did you talk to your attending? And then the nurse and the attending get together and start talking. And what do they say? Right? What's the person-centered thing to do right now? So you look at this gentleman and you say, he looks like he's doing a great job. I know he cares about his grandson. He's doing everything right, but he doesn't want us to do this one thing that really we need to do. So what do? You ask him, right? So they ask him, and he says, because I don't know if you're going to be putting something into his back or taking something out. And the history of medicine and people who look like me is terrible. He's right. In fact, it's smarter of him possibly to say no to us than to say yes. Just like in North Philadelphia, I didn't see vaccine hesitancy. I just saw a lack of trust. We have nobody getting the vaccine in Temple Hospital on one side of Broad Street. There's a mega church, Zion, where Leon Sullivan was the minister across the street. We asked the community, why weren't you coming? And they said, we don't trust you. Well, what would you trust? Do it in a place safe to us. Have people give this shot who we trust. There were lines, waiting lists to get the vaccine. So one of the things we're trying to do with the Gold Foundation is to create actual care spaces that allow this to happen. That the physical, that we take people's context really into account. We all learn about it, but we don't really enact it. And we need to remind each other the values and ethics. It's like the 6 blind people and an elephant. None of us sees it all. If you're one of those people and you think you know everything and you're blindfolded and you're standing by the elephant's trunk, you think the whole elephant is like a tree. And if you're on the tail, you think the whole elephant is like a rope. So we need to create spaces that allow this to happen. So what does this mean? What does this mean for how do we do this IPEC humanism work in a collaborative way? And I think if you look at these 4 stories, what would they look like? We are great at simulation. Medicine and nursing and pharmacy and all the different spaces. Let's simulate the neurosurgeon and the neurologist. And let's work through that, right? Let's do something like Tell Me More. Imagine if when you opened Epic, I know we'd have to help people not just click through it, but if you opened Epic and the first thing that came up is, this guy loves to dance. He was on Bandstand. The interactions that whole day for the team and that patient would be completely different. And what if we intentionally, I always say I'm a recovering student affairs dean, but the best thing about being a student affairs dean was I get to be the first person to talk to the students. And I would tell them one thing. I would say, I want you to make one assumption. I want you to assume every patient wants to be healthy. Every family wants their kid to be healthy. Every kid wants their parent to be healthy. So if it's not, it's a barrier. It's not a declaration that they're doing something wrong. So we need to structure our education differently. So then maybe we'll really see transformation. Then maybe we'll really understand, because people aren't dying in our hospitals today because I don't know which antibiotic to give, or or a nurse doesn't know what the side effects of a chemotherapeutic drug is, or that's not why people are dying. People are dying because they don't trust us. They're not telling us stuff. They're not trusting us enough to enact a care plan. So thank you very much. We appreciate your time and your patience, and we'd love to hear what you think and what your ideas and thoughts are from what we've shared. I'm going to ask Deb to come back up and join us. Yeah, I think they have mics for you because it's well, I think it's recorded for Dr. Hill. I think that's the thing.
Thank you very much. I think as nurses here, we have thousands of things rolling through our brain because we've, those very important things that's missed, that question that we don't ask, and or that look in the eye of someone who you're like, there's something else going on here that they're not saying. So I do believe that simulation can help, because you can't do it. I love that. I love you sharing the what about me. Just alone coming here to hear about that is just wonderful ideas. How do we get past some of the competition that is inherent working as a team, in particular in acute care, I guess I would say?
Well, so we can get past things like competition if we make that the priority, we've done it before, right? We have changed some things in medicine. You know, it's, again, I'm old. We never, how many surgeons threw things in ORs? Right? And I'm not in ORs now, but I'm hoping that doesn't happen so much anymore, right? And we can change it if we make it a priority. These are competitive people. So we say, yeah, this really matters. This matters. What your colleagues think of you is going to matter. That you're going to be graded on that. Because that's what happens when you're in the hospital. I'm graded on how well I work with nurses, and my patients, our collective patients together will get better care if I am graded better and the nurse is graded better by me. So I think we just have to make it so important. It's more important than if they know the pharmacokinetics of any drug. And we just have to make it part of their grade, I think.
I would agree with what Kathy said. And I think in addition to being intentional and taking it on head on is that we have to stand firm with what we believe in. I know from talking to some of the practice leaders that I've worked very closely with, it only takes one time when we allow something that we've said we stand against to happen. And if we do that even more than once, I mean, we all make mistakes. I think that's different though than saying something can't happen, but this person we're going to excuse for reasons that have nothing to do with behavior. So we have to be consistent. And when we make a mistake, and then we say that as well. But again, emphasizing during COVID, I called schools and I talked to people also in practice, and I got to volunteer at one of the hospitals being a vaccinator. They told me, oh boy, this is the best shot I ever had. You must have been doing this a very long time. So Kathy and I both get the old part. But one of the things that people said is where people were healthcare professionals, where there were areas where people were working well together, coming together as a team, respectful of each other. The competition wasn't about each other, but about what the things they were trying to achieve. That was a more satisfying environment. And it's so the more we can hold up those examples, I'm an optimist. I believe that that's what will help us.
Well, and just one other thing, about behavior change. We are good at it, right? Because look at central line infections.
Mm-hmm.
We've gone to almost zero because we changed people's behavior because we told them they had to.
It matters. Mm-hmm. Yes. Do you want to call in?
I'm just watching the
Yeah,
microphone.
go ahead. Oh yeah, watch them up here. There's.
Hi, thank you so much for being here. I'm a social worker, but I work with a lot of nurses. I work with some of these wonderful people in this room. As we see the growth of, and I don't expect you to have an answer, I'd just love to hear your insights. As we see the growth of these collaborative care models, and we know the research says that they work, what are your thoughts on how to advocate for funding to increase these collaborative care spaces and opportunities, especially outside of traditional hospital acute care settings, as we kind of wait for insurance company reimbursements to catch up with models we know work?
So very good question. And I wish I could give a lot of examples, but I do believe that there is increasingly more interest, certainly in the foundation world, for support for interprofessional work. Very few discipline specific in the association space, discipline specific work is getting supported. It needs to be connected to health equity, to in interprofessional work. Macy Foundation is a great example, again, of what we can find, but also communities. There have been, I'm in Baltimore, there have been support from small but local philanthropy groups that are supporting some of this work in different hospitals.
Well, and I think, and again, I do believe in trauma-informed care, but I think accountability is trauma-informed. It's this. The other place I think should fund this are the hospitals.
Yes.
We have to show them that if you do this, you will save money. You will save money because even if you prevent faculty, nurses and faculty physicians, or physicians and nurses from leaving, that's such an expense to a hospital to have to retrain people. So I think we have to make it an economic decision.
Here, somebody- yeah, keep coming.
Thank you. A quick observation. Hope I'm not taking it too far. I felt a lot of focus on inpatient interprofessional. I'd like you to consider this. We are in Wayne County in Michigan, the largest county. In this county, there are two sprawling, big medical centers, Henry Ford and the Detroit Medical Center. A comprehensive cancer center, one of it 50-some in the country. Up to yesterday, a one of its kind perinatology research branch, mostly for women and infant issues. The largest medical school on one campus, and increasingly the most diverse. Detroit Health Department, Wayne County Health Department. When you look at all these institutions and brick and mortar, and you contrast it with two things in Wayne County, the county continues to have the worst health outcome in the state, and I think it can compete nationally. The other thing, it has one of the worst healthcare disparities, especially among the predominant population, African Americans and everyone else in the outcome. So how can we take these benefits that are mostly in-house to go to where people who need us are?
Thank you. I'm very glad you brought that up because in addition, when that scoping review, which I should have mentioned, most of what's published is focused on acute care inpatient. And there's recognition in IPEC, one, that we need better publications about what's happening beyond that. But part of the discussion is that hasn't been a focus. The new competencies do focus broader. So I agree with you that I think all of us, we're, that's the future. And it's today and the future about how we think more purposely about the work and highlight that, because then we have the full system involved.
Well, and I think even though I'm a hospitalist, but I think the outpatient place is the more important place by far, but it needs a leap of faith because we're not going to get data like that for a decade. Because you're not going to see the change. I can see the change on one hospitalization, but if you're going to talk about changing an outpatient world, it's going to take you years and years. And we all have ADHD and we just don't have the patience all the time. Yes.
So from the other end, one of the fun thing about having all those programs is 10 accreditation bodies. And
I feel like I should say I'm sorry.
I've heard it before. But no, it's great because interprofessional, every single one over the last bit is interprofessionalism along with the EIA has been more and more a part of the accreditation. But by looking at this, it's almost, and some do it really well, I'm only speaking for the programs I have, is each one almost has defined IPE in their own silo and then created these activities. I'm familiar with all these accreditation standards, and some it's only one. And it's also focused on I don't get to my point, it's focused on the actual program. What you presented with IPAC is something that is overarching. So my question and maybe challenge is, can you work in these accreditation bodies to extend and actually standardize IPE to cut across all of these healthcare services so we're all learning IPE the same way? We're changing the behavior in the student. We're getting early, and as you mentioned, so how do we do that? Because I can tell you, IPE ranges from one standard to many, and it's different across all these bodies. So
Thank you. Before the pandemic, IPEC actually formed a subgroup, and I think it was 2 years, but I could be mistaken. That was the accreditors, and they met, and we all had great hopes. And then after the pandemic, the group has not reconvened. One of the factors that's very unfortunate, but in my own opinion, was that there was a passionate individual among the accreditors who really believed this was important. And I think having that champion, and I love nursing, but it wasn't the nurse that was championing this of the accreditation world. I think we've got to figure out how to ignite that again. But I will take it back also because I participate in IPEC. There's been discussion, but we haven't stimulated action from that entity to do so. And there's some other, the center, I'm blanking on the name of it, but there's other IPEC like groups that if we came together, we might have some more power. So it would,
But,
and,
yeah.
and it's still respecting the bounds of each accreditation group, because some are more prescriptive than others, but collectively.
But you're absolutely right. And we have to, however, we have to change that, legislate that, policy that. You're absolutely right.
We were getting there. You know, Sisyphus, you get that rock up the hill and then slide back down again.
Hi, so I'm a nurse. A lot of people have already kind of touched on this topic a little bit, but I come from a health system where we had 27 million in baskets and calls last fiscal year. I was wondering to pick your brain on how to apply humanistic principles to, you know, in a healthcare environment post-COVID has come down to basically just texting, you know, nurses and providers about their healthcare problems, and we just text back. We've gone from a more interpersonal relationship in clinic to an increasingly unpersonal relationship for, you know, patient care. Oh, and the second one is, are those numbers like for acute care, like the patient satisfaction, for example, do you think, or is it?
Yeah, I would go back to the article myself, but my understanding and recollection is that most of what was found in the literature was focused on acute care inpatient. There's very little published, and this is published studies that showed results. And there's still, so there's more that needs to be done. I think your comment about what we can do, and we're academic, the nurse, you know, the academic voice, if you will, for nursing, but we work very, very closely with practice leaders, and many of our members are practice. We're not divorced and separate. The conversations we need to have in all the health professions, but in nursing, have been in recognizing, you know, what's important to build the healthy workforce, and communication is critical. And yes, texting can help, but if we don't have the interpersonal communication that's strong, we also then don't have the trust. And when AHA has been reporting that the concerns the American Hospital Association has when it's been surveying the workforce collectively is that how one feels valued and one communicates and contributes in, and this is acute care, but in the acute care setting has been declining. And that because that communication itself has been deteriorating. I don't have all the answers, but I think we have to raise awareness and then be more intentional about what we do to correct that, because that's not what people want.
Well, and I think, you know, in a practical sense, so I have the fortunate job to run a foundation about humanism. And I'm going to tell you, I'm all pro AI and I'm scared of it all at the same time. AI could really help us here, because rather than spending your time answering the texts, it'd be great to have it noted that, okay, this person really needs a human interaction. AI can probably do the texts as good as we can, but they can't talk to the patient as well as we can. So I'd like to free up your time to call the person who did the text and let AI take care of the text. And I think it's the same in the room, right? Yeah.
And that's how we use AI to work for us.
But we got to be careful, because the slope of how it could go.
Oh, yes.
And try to replace the human connection is
Yes.
really scary.
One more thing then, AI in some healthcare systems already are just trying to at least categorize in basket messages between non-clinical and clinical, just to kind of do what you just said. So
Yes.
there's some progress being made on that.
Hi, my name is Cheyenne. I'm also a nurse as well. I was just wondering, how do you get students to be engaged? I know that when we do get the interprofessional like education sides, whether it's at work or sometimes even at school, and just talking to other interprofessional students, sometimes we get like this taskiness in it where we kind of skip like the real meaning and the reason why we're doing it because we're trying to get through it. And then also, how do you approach the older generation who might not be familiar with interprofessional collaboration? How do you get them engaged? So,
Well, I think that those are great questions, and maybe being part of the older generation, though, I hope anyway. I think we're in a time in medical and nursing education that's different than anything we've been in, maybe ever, because I think learners are more knowledgeable about so much than the teachers are. The place this has really got real with me was GFR and people who identify as Black. And arguments between students and faculty, students saying, why are you correcting the GFR? That's wrong. It's racist. Race is a social construct. The students are right. And the faculty are standing there on their last breath saying it's real, it's true. And I think it's the same thing for interprofessional education. Sometimes we just have to say, this is what has to happen. But it's the C-suite. That's why you're so lucky to have these guys, but every place doesn't have these guys. And it's the C-suite in the hospitals. And then it's going to be unfortunately, the accrediting bodies. It's JACO, it's
And I do think we're seeing more from the accrediting bodies of requiring, and I agree with Kathy that the leadership is exceptionally important. I also think the commitment to listen to the voice of students. Many of you are familiar, there's a little PowerPoint about the difference between equity and equality. And it depends on how you look at it, but it can be just almost cartoon-like. And it shows 3 children. And initially, when you're looking at equality, you're seeing the different size children, different boxes looking over a fence. And then equity, they all had the same size boxes. And then when you look at equity, they've got different size boxes. I was speaking to a group of graduate students and they said, well, why don't we just remove the fence? And that's what we need to be able to, and it was actually at a health system, and the health system was talking about doing things. And so they moved away from different size boxes. So we have to recognize, hold up, incentivize the great ideas that come from students. I am hopeful that we have the older generation embrace and or retire. I think we have to see that it is a new day, and that's.
and not just students, but younger faculty.
Oh, yeah.
Faculty,
And
younger nurses.
It may not be age young wise, but even, professionally where your experience is, there's nothing like having a new lens and looking at a situation that can have a really even well-meaning person have looked at it for 5 years and not see the difference. So that's a part of it. And then again, we said it earlier, but for all of us, resilience, and for all of us having support. I'm an optimist, and I can't tell you how many times in the past couple years I felt like, oh my, I don't know if I can really, whatever the issue is, stand up. And it's been my health profession colleagues as well as my family, but who have really helped me. So I think being able to count on each other. And this is an extraordinary partner that I count on. But anyway, I went a little off script there, but.
So I guess I have maybe more comments or things to share. I am a proud prodigy of Virginia Rice's tutelage she was on my dissertation committee, and is an amazing woman. There's a couple of things that you all said, and this young student said earlier. There are a lot of, I think, people who have left. Yeah. Kathy, you're saying you're old. I am older than dirt. I came out of retirement during COVID because we needed to help So I joined 3 medical reserve corps, Detroit City, Washtenaw County, where I live, in Livingston County, and had really interesting experiences. In Detroit, we went to churches and we went to senior housing and we went to people's homes because that's where people were comfortable getting vaccinated. You know, in Ann Arbor, we went to Eastern Michigan University's basketball center and people came there. So it was very variable and people had to be willing to pause and talk to each other as a team. And it was incredibly interdisciplinary work. I mean, I vaccinated with doctors and nurses and, you know, my husband's primary care, retired primary care physician, and corpsmen and EMTs, and every stripe of person was there just working together and trying to do the right thing. So I do think that there is a general belief in healthcare that we always can come together if we have to. I do think that administration, and I sat in the C-suite many times in my life, can get in the way. But I also think that if they're approached properly, I think their big push and the other people we have to get to are the policymakers and the insurers. The insurers block a lot of the creativity in healthcare. And you have to just work that. And it's like, you know, I'll probably be doing that 37 seconds before I drop dead because it's an ongoing, yeah, I will. It's just an ongoing issue. I'm a Wayne State devotee, but I live in Ann Arbor and I have watched, I'm a pediatric person. So, and I was the chief nurse consultant for our state children's special healthcare services program for a decade. When we were moving family-centered care into the pediatric world. And now much of the adult world is embracing through offices of patient experience and patient and family-centered advisors.
Yeah.
They're really trying to do interdisciplinary work. I have pharmacy students. I'm not a pharmacist, I'm a nurse. But I was with 2 pharmacy students that I'm mentoring for this academic year. They're doing really good stuff. And one of the things that you may be interested in is they are using the child life model and they are creating family life specialists.
That's great.
Who are working at the cardiovascular center strictly right now at U of M, but really moving, their principal role is to relieve the nurses, to give the nurses the time that they need to do the clinical work that they need to do, and the family life specialists, who are all child life specialists,
Right.
are spending time in critical and important conversations and getting to know the patients.
Well, it's about time people realized pediatrics had it all figured out.
Yeah, I know. I've been preaching that for years, but so your comments have been fabulous. Thank you to both of you. I'm just buried in the APRN consensus model right now because I'm also a mentor to the Advanced Practice Nurse Council at U of M. And there's so many APRNs that are being underutilized because of laws, because of policies, and because of insurers. So
And
there's always lots of work.
As you said, lots of opportunity there for us too, policy and otherwise. So
And Ishmael
thank you
Ahmed
for
is an
your
old
work,
friend of mine
sure.
from Access.
thank you. Thank you.
So I'm both academia and clinical practice. I work in a primary care clinic that's a federally qualified health center in a health department, Wayne County Health Department. And one of the things that I was challenged with when I took the job there was to create a culture of inclusivity because the previous providers had alienated the public health people. The good news is my master's is in community nursing. And so it wasn't a big leap for me. And the collaboration between what the health department does and what we do in primary care has been phenomenal. But the challenge for me has been to see what's happened to public health. I have patients who can't get immunizations at the Wayne County Health Department because they can't have insurance. And I'm just like, this is nuts. Like they're willing to get it and they can't get it. They have it, but they can't get it. And I think that that's a public health issue where we've divested public health and made it other and not part of this bigger picture. And I would say the other challenge for primary care providers is the inequality in how payment systems pay primary care providers. Because what it forces physicians to do is make a choice, and I don't blame them. Education's expensive. Going to the places where they're going to be able to recoup their money faster sometimes by doing specialty care. And I see in the federally qualified health centers, lots of providers get their loans repaid and then go into specialty care. That means that there's plenty of room for us in primary care, but we need to invest in it.
Yes.
And that's what I haven't heard, is how we're investing in healthcare in a culture of inclusivity, because that is what the problem is with the sizes of the boxes and the fence that's in the way.
So you raised some very good points. One thing that the optimists will tell you is that I think payment reform, while it's always been difficult, is going to be even more difficult in the coming years because there aren't additional funds. So it's going to be moving money from one pot to another. And I love my colleagues in the other disciplines, but as soon as just in our microcosm of the world, as soon as we want to pull money away from one to give it to another, I don't want to do it. I had a call with a congressman who wanted to invest in a particular type of nursing education without support for progression and take money away from what we needed to do. And I am a well-intended person, but if we have that, I think as a dynamic, that is in the federal government, that's a challenge. So it doesn't mean we don't continue to advocate, but I am not going to suggest that I think there's going to be immediate reform. Same with those who want nurses to be taken out of the cost center and paid. I don't believe that's going to happen immediately either. It takes too much change. But there is recognition that the public health system isn't. I mean, you could argue the healthcare system isn't either, but I do think we're likely to see more policy advance there. I think the next at the federal level, and this isn't a party statement, this is a general statement. I think advancing policies that support the health professions in the next year or two for all of us are going to be challenging. So again, another reason why coming together as a community. So I'm sorry, I don't have a better answer to give you.
And the only thing I would say is we need to make what the Affordable Care Act was all about really happen. People need to be held accountable for health, not for treatment of illness.
Yeah.
Was there one more? Or are you good?
Thank you. Thank you. Thank you.
Yes, please stay for 1 second. Thank you very, very much, Dr. Trautman and Dr. Reeves, for this very thought-provoking conversation. And I appreciate all the questions from the audience. Two very small tokens of appreciation from the College of Nursing.
Thank you.
Yes, thank you so, so much for.
Yeah, you get it. Thank you very much. Green is my favorite color.
Oh, good. In here are boxes. I'll give those to you to take with you. So again, thank you, Dr. Rice, for your contribution and generosity to make this even happen. I hope you enjoy this when you see this with Garrett. So before we move to the reception, I just 2 points. I wanted to really thank the committee and all of the individuals who helped to put this on. I know I won't remember everyone's name, but thank you, thank you, thank you. If you helped to support this behind the scenes, please stand up for a half a second so we can say thank you to you. Oh, guess they're out in the lobby, the rest of the other people standing up. And then just a reminder, tomorrow you'll be getting an email from, I don't know if it's coming from you, Kristen, or from Dr. Genuine. Coming from Alyssa Genuine. She's our research assistant in the Office of Health Research, and that will be your evaluation form. You need to fill that out to get your CEUs, but also to give us valuable feedback about how things went today. So thank you again, and join us in the lobby for a reception.